Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.
Breast cancer, early diagnosis. Think A to G. Our specialist is Miss Claire Garnsey. A. Assessment.
If a woman is coming in on the 2-week wait pathway, they're coming into a triple assessment clinic, and that's absolutely standard. So it should be triple assessment wherever you are in Greater Manchester or Cheshire.
B. Breast pain.
Breast pain is not a sign of breast cancer. And in Greater Manchester, we've done a really extensive audit over COVID actually, looking at patients who've presented with breast pain, who've had a mammogram, and what is the pickup rate of breast cancer. And in women over 40, it is 0.4%. So you are just as likely to have a breast cancer if you've got head pain or elbow pain as if you have breast pain. The two are not linked. It is just like doing another screening mammogram. So we need to be very clear on this with women who report breast pain. Breast pain is unfortunately very normal. Most women will have breast pain. For some people it is cyclical, but for some people it is more constant. And we don't know why it occurs in one breast and not the other, but that can happen.
C. Cancer of the breast tissue in men and transgender patients.
Breast cancer can still happen in men and in transgender patients. So with cisgendered men first, it's about 350, roughly, males will be diagnosed with breast cancer in a year compared to 55,000 women. So it's a very small proportion, but it still can exist. So just know that it's there. It is not going to present as gynecomastia. So it's not going to be, again, bilateral, diffuse enlargement of the breast. It will again be a focal mass, a nipple inversion, a change to the skin, or a discharge. And for all those same symptoms and signs, you would refer in on the 2-week wait pathway. Regarding transgender patients, I think it's really important just to understand what surgery is done. So if we have a trans man who was born with breasts and has had chest contouring surgery to give him a flat chest, it is not a full mastectomy. It's chest contouring surgery. So he will still have some breast tissue over that chest wall. And because he's registered as a man, he will not get called for breast screening. So it's really important that we're trying to get that message out there to trans men that they still will have some breast tissue after their chest contouring surgery, and they can request screening after the age of 50. So they can request those 3 yearly mammograms. For our trans women, it's a bit easier because they're on hormones, they have breasts, and they're registered as women. So they will automatically get called for screening at the age of 50, like any other woman.
D. Discharge.
With nipple discharge, it's a very common referral into the breast unit, and it's very important to remember that nipple discharge can be physiological as well as due to an underlying pathology. So with discharge, it's a unilateral, uniductal discharge that's occurring spontaneously without pressing, and is also bloody or clear.
E. Examination.
You definitely want to be referring on a 2-week wait pathway to your local breast unit. A lump in the breast or the axilla, a skin change, so a skin tethering or indrawing of the skin that might indicate that the cancer has grown into the skin and is drawing that skin in, or peau d'orange, where you've got peritumoral edema changing the skin texture. Also skin changes to the nipple. So when there are flaky skin changes like eczema on the nipple, you want to note whether that is related to a flare-up of eczema in general. It sounds obvious, but we do get quite a lot of referrals where people are worried about Paget's disease of the nipple, but actually there's a flare-up of systemic eczema, and the eczema is bilateral, and that doesn't worry me. It worries me if there's an eczematous change on one nipple, and particularly if it starts on the nipple promontory rather than on the areola around the nipple. That's more concerning for Paget. But we would like to see ladies, if they have a new unilateral nipple inversion, we would want those ladies to be referred in.
F. Family history.
NICE guidelines are really clear on when you refer in. So that is a first degree relative under the age of 40 with breast cancer, a first degree relative with bilateral breast cancer under the age of 50, and a male with breast cancer in the family. And then you're looking at those first and second degree relatives. So if you've got a first and second degree relative with breast cancer or breast and ovarian cancer, you need to be referring in. It's quite a limited history because you're just looking at first and second degree really. So we don't need to know about the first cousins and once removed. Keep it short, just concentrate on first and second degree and you'll be very safe. And if in doubt, contact your family history clinic if you've got an odd, unusual, complex family history of cancers.
G. Greater Manchester referral proforma.
And it gives some just really quick pointers about breast pain, about physiological nipple discharge that doesn't need referring in, and also about what to do about a family history patient or a cosmetic patient, those effective use of resources patients with requesting reductions or augments or congenital symmetrization surgery.
Think A to G. A. Assessment. B. Breast pain. C. Cancer of the breast tissue in men and transgender patients. D. Discharge. E. Examination. F. Family history. G. Greater Manchester referral proforma.
GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.